This is just a brief update on BEST CLI and how it'll potentially affect my practice and some of yours as well. These are my disclosures, and I have nothing to disclose for this talk. So what's the concept of BEST CLI? Well, there is, to some extent, clinical uncertainty about the best method to revascularize patients who have chronic critical limb ischemia, and this led to the design of a randomized trial to answer this question. Now, BEST is a National Heart, Lung, and Blood Institute-sponsored multi-specialty randomized control trial designed to compare treatment efficacy, functional outcomes, cost effectiveness, and the quality of life, comparing endovascular versus surgical treatment. So what's the genesis of this? Well, the genesis really is that lower extremity bypass using autogenous vein conduit was for many years the treatment of choice. And certainly that's what I was exposed to when I was in training. It's been advancements in endovascular devices, delivery systems, as well as an improved expertise in the performance of endovascular therapy, which has been heralded throughout this entire conference for the last couple of days, that's led endo to be first-line therapy at many centers. Now, this is actually just reported in February of JVS. They reported enrollment for the BEST trial, that it surpassed 50%. They had 1,567 patients enrolled as of January. And this was their projected enrollment is 2,100 patient goal for the study, which involves more than 150 centers. And so while very well designed to compare the effectiveness of surgical and endovascular interventions for CLI and to stratify for those key elements such as available conduit, tissue loss, and some other anatomical and clinical factors, enrollment has been a real challenge. It's been very difficult and certainly been difficult for our center. So what are the barriers? Well, there are many patients with CLI that are poor candidates for surgical intervention. They have multiple comorbidities, they have poor functional status, they have advanced age, all of which makes them poor surgical candidates. Now, there's also a patient and family bias about the advantage of less invasive techniques. No one wants to have an operation if they can help it. The idea that you can have a shorter recovery and that this is more easily overcome clearly is an advantage for the patient, but it is a bias that we need to overcome. And then there's the inherent center bias by the practitioners favoring one technique over another. And this really depends on the expertise and experience of the interventionalists and surgeons at your center. So there has been significant divergence in practice pattern, and this exists with regard to how we select procedures for these patients. So data from the VQI, which is the Vascular Quality Initiative, demonstrates wide variability in the percentage of CLI patients treated by bypass versus endovascular therapy, and the percent of bypass varied anywhere from 0 to 100% by participating centers, with 31% the infrainguinal for all of the VQI centers. And this just represents the graphic. So you can see the procedural selection variation, bypass at 0% versus 100%. And so you have this wide variability depending on the expertise of your center, and that clearly some centers are not sending anyone for bypass and other centers are sending everyone for bypass. So what about endovascular development? And I would submit to you that this is really one of the biggest barriers. The development of advanced endovascular skill set and improved devices has allowed for successful treatment of highly complex lesions that previously were not well treated. Innovations such as small delivery systems, stenting, atherectomy, drug-eluting technologies, they've all significantly impact on improved clinical outcomes. And alternative access, again, is just demonstrated by, again, many of the really fantastic cases that we've seen in the last couple of days, such as pedal and tibial approach, has allowed revascularization, particularly of long segmental occlusions in the infrapopliteal and infrainguinal segments that were not possible before. So clearly there's an impact of local expertise. There remains heterogeneity in the resources and skill set available at different centers, and I think this is something that you have to look at your specific center. Surgical expertise with endovascular techniques is variable, and many new young surgeons are more familiar with the endovascular approach than they are with traditional surgical revascularization. In summary, BEST is an important trial that will hopefully provide data that will allow the development of guidelines to help us decide what's optimal treatment for patients with CLI. The dynamic nature and evolution of endovascular devices and procedures poses a challenge to the willingness of physicians to randomize patients And local expertise is really the key, and the willingness to overcome personal bias before we have better answers as to what the best approach is for our patients. And I thank you for your attention.